to Physician Focus. I'm Dr. Bruce Carlin. Physicians undergo years of education and training to promote wellness, cure illness, and preserve and protect life. But we're also conscious of the inevitability of death, and in recent years, hospice and palliative care and end-of-life issues have become important issues. This edition of Physician Focus will examine the topic of advanced care planning. We'll discuss what it entails, why it's important, why it should begin early, and how to go about it. With me for this conversation are Dr. Beth Warner and Dr. Eric Rines, both members of the Massachusetts Medical Society's Committee on Geriatric Medicine. Dr. Warner is board certified in internal medicine, geriatrics, and hospice and palliative care medicine. She is a consultant geriatrician with Cooley Dickinson Healthcare in Northampton, Massachusetts, and medical director of the Linda Maynor Extended Care Facility in Leeds. Dr. Rines is board certified in internal medicine and has practiced as a primary care physician and hospitalist in communities on Boston's North Shore. He currently practices geriatric medicine with Element Care in Lynn, Massachusetts, and chairs the Medical Society's Committee on Geriatric Medicine. Welcome to you both.
Thank you.
This is a very important topic. Beth, what do we mean by advanced care planning?
Advanced care planning is the process through which we make some very difficult decisions for when our health care becomes challenging, often towards the end of our life. This includes talking to our healthcare providers and our families, and often also includes completion of certain documents that can outline your wishes.
So what are the other things that it includes? So you have documents that you form, you have the discussion that you have. On a patient that's coming in, I'm 30 years old and I'm not looking at any major illnesses. Why would I have this discussion?
For a healthy 30-year-old, the discussion can be fairly simple. Whether we like to stop and think about it or not, we all know that we will pass one day. And we all know people who have been in very unexpected circumstances, be it with accidents or illnesses. So we encourage everybody, even as young as 30, even as young as 18, to first complete a healthcare proxy form, which outlines which person you choose to make healthcare decisions on your behalf if you are unable to.
I agree. Bruce, when I was in primary care medicine starting at age 18 and all the way up, I would, at a routine physical exam, on their way out, even an 18-year-old, I'd make sure they get the healthcare proxy form to start thinking about the future. And even start talking to the family.
So it's part of good health just to have had the discussion. I know who I would trust enough to make decisions when I'm incapacitated.
Exactly.
So that's one part of it, but the advanced care planning goes beyond that. What other advanced care planning things do we do?
Well, just in general, the attitude about thinking ahead, we all do that anyhow. We make out wills. We get life insurance, we get from our employer, if we're fortunate, we get pensions or 401ks. So we're always planning ahead for our future. And this is another part of it, the medical part, because we know someday something's going to happen. And, Beth was talking about the details, and we can get into those.
So obviously it's not just for the elderly, it's for everybody to a greater or lesser degree depending on your situation. But as we accumulate debilities of various sorts, some of this comes into play. Can you draw a distinction? We've used the terms advanced care planning, we've used the term palliative care, we've used the term hospice. Can you help me differentiate those?
Absolutely. Advanced care planning is the catch-all term for the planning that we do as our healthcare becomes complicated and as we need to navigate challenging decisions often towards the end of life. Palliative medicine refers to the type of care that is delivered when somebody is diagnosed with a life-limiting illness. We talk about the curative piece of that care if possible. Is there chemotherapy available? Are there medicines to help my heart beat better, stronger, longer? But there's also the piece that with these illnesses comes the burden of not just planning for the future and the emotional pieces of that, but also the physical pieces. Oftentimes there's pain, breathing troubles, anxieties, there's physical pieces.
Or just support.
Correct. There's a lot of social pieces that need to happen as well. A lot that needs to happen on the family front and the personal care piece that may need to happen for some people. So palliative medicines, let's take a step back and let's not just think about what the next chemo is, what the next drug is, but let's do nice comprehensive planning with you and let's be there for you every step of the way.
So palliative care is not the same as hospice.
Correct.
Hospice can be a part of palliative care, but maybe you can help us with what is hospice.
Correct. Hospice care is it's a wonderful care for folks who are entering the last months of their lives. Most folks who qualify for hospice care have been told that they have a diagnosis that may mean that their life expectancy is 6 months or less. And that is a part of palliative care, and the service has become much more robust within that hospice care team.
I was lucky to have hospice help my father in his last 6 months with his cancer, and we were able to care for him at home. It was beautiful. All the, the oxygen, the hospital bed, the equipment, and the people, the nurse who came in. It was a wonderful service.
So you knew about it seems.
I knew ahead, but still having the personal experience was very powerful.
What I'd also say is that I've had patients, I've got one patient right now who is on hospice for his 3rd year. Mm-hmm. They kicked him off after 2 years, and he's got end-stage liver failure. And I would say that having hospice there has provided him with more services than he ever would have gotten if he had done it a traditional route and said, well, I'm not ready for hospice.
And Bruce, it prolonged his life too, I'll bet.
Oh, absolutely.
I think he would have died sooner if he had had a lot of aggressive care and
well, maybe
out of the hospital.
Maybe you could speak to that. Palliative care and hospice in general, I think there are studies that speak to that. Certainly
there are. I know Beth is much more expert on that, but there is certainly a study of advanced lung cancer where a group got aggressive care, chemotherapy, surgery, radiation, and another group got palliative care. And the palliative care group lived longer and had better quality of life. And that's just one. There are many other studies I'm sure you know of. And I got to say that palliative care, people have the impression that when the doctor says, oh, there's nothing else we can do for you. But there is a lot more we can do for you. Palliative care is not no care. It's a different kind of care. It's the appropriate care for the condition you have now.
So tailoring your wants and needs to the treatments that are available, sort of a better meshing of knowledge of your disease and its treatments, and providing the supports. So how widely how good are physicians at doing this?
I think physicians are getting better every day now. I think many doctors were not trained to have these discussions. You know, in many oncologists, for example, we're trained to talk about diagnosis, prognosis, next treatment, and not necessarily changing our focus, not necessarily talking about some of these aggressive treatments may end you up more in the hospital or in the nursing homes, whereas some treatments may help to have you be more in a home-based setting longer. So it's stepping back for most doctors to think big picture, which doctors are more trained to think problem focused. But it's training doctors to step back, think big picture, and help people plan for these important decisions.
Well, I've been very impressed with our oncologists where I work, that they put these quality over quantity of life issues up there, and I think that's coming much more into the discussion and among physicians as to where are we really going with this, and our palliative care teams are really honed in on speaking to the patient and speaking to the family and setting things up. So you said we're getting better, but how much better are we getting? What percentage of docs get say as much as a healthcare proxy with their physicians, with their patients?
Yeah, that's a great question. Studies from the 2010 era would indicate we're not doing a very good job. Yet we have little studies and little niches where we see things are getting better. In my area in the western part of Massachusetts, we've had a lot of grassroots initiatives as well as healthcare initiatives to talk about advanced care planning. And we've seen many more people asking, do you have a healthcare proxy form? How do I get a MOLST form? How do I get my wishes in writing? So we're seeing it with many of these grassroots efforts, the Conversation Project being probably the best well-known of those. More people are talking. So I think some of it hasn't necessarily come from doctors having better training and now doing more conversations, but people asking their doctors, how can I do this? Please help me with this.
Do you set this up in your own practice? You said you were doing this, however many years, 20, 25 years ago, that you were saying, do you have a healthcare proxy? Do you set this up in your practice as a regular routine, as a regular office visit routine?
Well, I appreciate the opportunity to talk calmly with you and the general public about this, because when I was a hospitalist, in crisis situations I'll give an example, an elderly person who's been sick for years and now is in the intensive care unit on a breathing machine, on a feeding tube, and the family is fighting with each other and fighting with me and the specialists and the nurses. And I wanted to step out of my doctor role and put my hands on the family's shoulders and look them in the eye and say, this is precious time. Your father's not going to be here much longer. Now's the time to show love and reconciliation. But I couldn't do that, and it was so frustrating to me. And that's why I changed my work some years ago to do geriatric care with this PACE program. And now the way I approach it is when I'm taking a history from a patient, and I get to asking about their family history and what happened to your mother and your father and brothers, sisters, so on. And in conversation, I find out they often might say, I don't want to die the way my mother died. And so I ask, well, what happened? Well, she was on machines. They were doing all kinds of things to her. She suffered for 2 weeks. We couldn't talk to her. And I don't want to die that way. And that opens up the conversation. What would you like for yourself? And we go one step at a time as I get to know the person, and they can define more and more what's important to them. And they can change their mind as time goes on, that's fine, but at least we've started the conversation.
And you get that conversation, that important conversation of quantity of life isn't the same as quality of life, and a nice death is a blessing for many patients, as opposed to a more active death that may help some of the family grieve, but certainly is burdensome for the patient. We see it all the time.
sad but true.
Yeah.
I felt so terrible working in intensive care with so many patients who I felt I was just a cruel torturer. I didn't want to do that anymore. And I think more and more doctors are feeling that. And the nurses knew it long before the doctors.
They're way ahead of us. They're way ahead of us on
And
this.
and I love that our patients are increasingly more activated and willing to ask. You know, a woman I met recently in the hospital in my role as a geriatric and palliative care consultant, she was hospitalized for the first time in her early 80s. And she relayed the story of seeing her husband the past through years of his life, where he was diagnosed with kidney failure, heart failure, put on dialysis, became weaker, lost weight, was falling down, in and out of the hospital. You know, you need this drug, he needs this dialysis, he needs to go to rehab, he needs to stay long-term in the nursing home. And nobody ever stepped back and said,
what do you want?
We're looking at the last few years of life here. How do we navigate what's most important? How do we get you what you want? So here she was, her first time in the hospital, being diagnosed with the exact same conditions her husband had, saying, I want to talk to the palliative care doctor now. I want to know what my options are, so as things get more challenging, I can choose the care that's best for me.
So, what's the physician's role in this? How do we speed the process, or how do we catalyze the process? I guess that's what would you expect in your routine office visit?
Yes.
You want to talk about this?
Absolutely. I think that's a wonderful time. The Committee on Geriatric Medicine of the Massachusetts Medical Society recently created this brochure about planning ahead and knowing your choices. And this helps to walk both people, patients, healthcare providers through the process of advanced care planning. So it talks about which documents patients should complete at various stages of their lives, and it gives different resources as well that both patients and healthcare providers can go to help understand what options are. I hope that we're doing a good job as well at educating our colleagues on what palliative and hospice options are and when they are available to folks, and how to access those.
So are there other considerations that that we should be telling families about? What's the importance of this? Is it, you mentioned, Eric, the turmoil that happens when you're trying to do all this planning during crisis.
Right. All the turmoil during crisis, and especially as a hospitalist, where I'm a total stranger to the person, the family, and there's a lot of trust issues that are a problem then too. And so I had to say, you don't know me from Adam. You don't have to trust me. And but if we can step back and in our primary care practice talk about it, then we can hopefully avoid some of that crisis. I will say this: it's not always easy in primary care either, because often if for instance, lately we've wanted to get everybody have a MOLST form in our practice.
Explain the MOLST form briefly.
Medical orders for life-sustaining treatment. And this is a form that was promulgated in Massachusetts. Now it's in use about a year, I think, across the state. Well, say 2013, it became in common use. It's a pink form, and it helps start the conversation. So people with life-threatening illness, or life-limiting illness, I should say, who are starting to think what they might want for their future, they can make a choice about resuscitation, about dialysis, about tube feeding, intravenous feeding. They can put their choices on. Or they can say, I don't know yet. There's a place to check off. I don't know. And that's fine.
So I think this, so you've got a patient with chronic lung disease, for example, and you get the MOLST form in front of them, and they say, well, what do you think about intubation? And they'll probably have a better sense of that than the person that's never had trouble breathing. Mm-hmm. And it starts a very good conversation that can carry over. I would say, as much as you say that you're a stranger to these patients, I would say I'm impressed at how the hospitalists move right into the role of taking important steps at appropriate times,
yes,
and being compassionate about things.
I've been impressed also, yes.
There's a lot of fragmentation, but people pick up the ball. I'm very impressed with how the handoffs are made, but it's important to have something to hand off.
Yes.
So what other considerations do you think are important in this, Beth? You have other thoughts on this?
I think coming back to some of the scenarios Eric talked about with folks in the intensive care unit, and you were talking about talking with the family, which meant you weren't talking with the patient, or to a limited extent. 75% of people hospitalized with critical illness can't make their own wishes known at that time. They need a surrogate decision maker to be making their decisions on their behalf. And I believe it was a similar number, 75, 80% of folks who had to make end-of-life decisions in the critical care units on behalf of their loved ones had post-traumatic stress symptoms afterwards.
Because they hadn't had that earlier conversation.
Correct. Those that had had the conversations earlier, much less post-traumatic stress afterwards. So having these conversations, letting your families know what you want in these very serious circumstances, really takes the burden off of them, for your loved ones to be able to say, I know Mom wanted this, this is what she told me. I know my brother wanted this, this is what he told me. It takes the burden off, saying, you know, am I making a decision that might end his life that he wouldn't want me to make? It can take the burden off the loved ones to do some planning ahead of time.
You also have conversations about the true value of resuscitation, and can get out important words about the fact that resuscitation only works in 20% of the time, if that. And have
the statistics for somebody with multiple illnesses,
is even worse.
Elder.
Yeah.
The chances of them, you can resuscitate a small percentage, perhaps 20%, but for them to actually make it to discharge and make it home, that's almost unheard of.
And yet we ask people that are moving into this situation without some advanced planning and burdening them with a decision that's almost a false decision. But we can help them by doing it early and doing it forcefully.
Yeah, and revisiting every step along the way. Things get more complicated. A new hospitalization, a new diagnosis, becoming bedbound. There are different things that happen along the way. And interestingly, while I gave those medical scenarios, I was giving a talk where I gave these medical scenarios where we need to revisit with our patients what their wishes are. And they said, no, doctor, that's not the way we do it in real life. We want to have these discussions when our loved one dies, when our kid graduates college. We want to have these conversations when our lives are taking major changes, not just our health.
And do it every time?
Interesting.
Yeah, I think a little bit here and there, oftentimes when somebody loses a family member, there's a lot of reflecting on what went well, what didn't go well, and therefore what I would want if it were me, or what I wouldn't want if it were me.
Well, this could expand quite a bit more. We could talk a lot more. There are multiple issues in palliative care and hospice, but I think we have time for some major messages. What would you tell your patients as a major message, Eric?
Bruce, I have told patients who are facing terminal illness, and they say, I'm praying for a miracle. And I say, I believe in miracles too. I believe in the miracles of dignity, the miracle of comfort, the miracle of love, the miracle of peace. And I think if you work together with your healthcare team, we want to help those miracles to happen. And I think planning ahead will even help it better.
Those beautiful thoughts. Beth, do you have some words for patients that you would like to spread to?
Yes, thank you. Healthcare can get complicated, and especially as we accumulate more illnesses and become frailer, it can become very complicated. And we need to be able to step back, think about what we really want, what's most important. And then we need to communicate that with the healthcare team, and we can help you get there. I want everyone to know their healthcare providers are there for them. The Mass Medical Society is there for them. Please talk to us. If we don't open the conversation and these are things on your mind, ask.
Well, thank you both, Dr. Warner, Dr. Rines. This has been a wonderful conversation. For more information about advanced care planning and end-of-life care, visit the websites listed at the end of our show. And to view past physician-focused programs, visit our website at physicianfocus.org. I'm Dr. Bruce Carlin. Thank you for watching.
I'm Dr. Beth Warner.
I'm Dr. Eric Rines.
End-of-life issues will reach every one of us at some time, either as a patient, a loved one, or family member.
As physicians who specialize in caring for elderly patients, we recognize how death and dying can affect seniors and their families.
That's why we urge you to learn about advanced care planning. It's important to prepare well for end-of-life care, making sure your preferences are known if you're unable to make decisions for yourself.
Advanced care planning includes creating documents such as a healthcare proxy and medical orders for life-sustaining treatment. They ensure that your wishes are fulfilled and provide peace of mind for your family and loved ones.
For more information and a copy of our brochure, Planning Ahead, What Are Your Choices?, visit the Massachusetts Medical Society at massmed.org.
I'm Dr. Christopher Quinn. Ever since 1799, when Paul Revere chaired the first Board of Health in Boston, local boards of health have been protecting our public health. While invisible to many residents, the work of the municipal health official plays a crucial role in protecting our health and safety. Boards of health act as the local arms of the state departments of public health and environmental protection. They are given legal authority to set and enforce regulations, and their work covers a wide range of activities. Among their functions are disease prevention and control, food service and restaurant inspections, regulation of the sale of tobacco to minors, enforcement of the housing and sanitary codes, the oversight of disposal of hazardous and solid waste, and the protection of the environment from damage and pollution. To learn more about how your Board of Health protects you and how you might help, visit the Massachusetts Association of Health Boards at mahb.org.